Welcome everyone. Today we will understand what deep brain stimulation actually does to brain circuits. We will use ESSTN in Parkinson's disease as our model. This is the fourth episode of Functional Neurosurgery Explained. By the end of this talk, you should be able to follow a dBs pulse from the electrode to the axon to the whole network. Link the very fast clinical effects to the disruption of pathological brain rhythms, and understand the three main mechanisms we believe are behind the therapeutic effect of deep brain stimulation. Let's dive in. Let's start with the hardware. What are we actually putting into the brain? We implant a thin lead about 1.3 millimeters in diameter with several contacts at the tip. This lead is fixed at the burr hole, tunneled under the skin, and connected to a pulse generator in the chest. From that pulse generator, we control four main things. Which contacts are active, how big each pulse is, the amplitude, how long each pulse lasts, the pulse width, and how often pulses are delivered, the frequency. So DBS is essentially a chronic programmable pulse generator inside the brain. Now, why do mechanisms matter? Because the time course of benefit tells us DBS is not doing just one thing. Think of a typical Parkinson's patient. Tremor can improve within seconds of switching on the device. Rigidity and bradykinesia may take minutes or hours. Dystonia, especially with GPI stimulation, can keep improving for weeks or months. If DBS were simply a reversible lesion, we would expect one clean time course. But we do not see that. This suggests at least three layers of mechanisms: very fast electrical and oscillatory effects, network level changes over seconds to hours, and slower neuroplastic changes over days to months. Let's start with a simple idea. An oscillation is a repeated rhythm in brain activity, going up and down over time. Neural populations do not fire randomly. They tend to organize into these rhythms, or oscillations, at different speeds. That speed is called frequency, and it is measured in hertz, the number of cycles per second. In the motor system, two frequency bands are especially important. Beta, roughly 13 to 30 hertz, is dominant at rest and normally drops when you move. Gamma and other high-frequency activity rise during movement and support active processing. In Parkinson's disease, beta becomes too strong and too synchronized. Instead of brief, flexible bursts, you see long, coherent beta episodes across cortex S, T, N, and GPI. These prolonged beta bursts correlate with bradykinesia and rigidity, and they persist even when the patient tries to move. You can think of pathological beta as the network insisting on blocking new motor programs. So, a central question for deep brain stimulation is: how does stimulation disrupt this pathological beta and free the system to move again? Very briefly, let's remind ourselves of the basal ganglia loops. There are three classic pathways: the direct pathway, striatum to GPI, and substantia nigra pars reticulata. This pathway facilitates movement. The indirect pathway, striatum to GPE, then to STN, then to GPI and SNR. This pathway suppresses competing actions. The hyperdirect pathway, cortex directly to STN. This provides very fast cortical control of basal ganglia output. In the healthy state, dopamine keeps these pathways in balance. In Parkinson's disease, dopamine loss shifts the system towards excessive S, T, N, and GPI activity. The output to thalamus and cortex becomes overly inhibitory, and we see bradykinesia and rigidity. So when we place a lead in the STN, we are sitting in a key control node at the junction of indirect and hyperdirect pathways. Now zoom down to the single neuron. A neuron collects input integrates it, and if it reaches threshold, fires an action potential along its axon. For DBS, one principle is crucial. Large myelinated axons have a lower activation threshold than cell bodies. So when we deliver current, we are most likely to activate axons and passing fibers more than cell bodies. When many neurons and axons fire together in a rhythmic way, their summed currents generate the local field potential, the LFP. On the LFP, those rhythms appear as beta, gamma, and other frequency bands. In simple terms, each oscillation is just the large-scale echo of many individual action potentials that are firing in step. This leads us to the volume of tissue activated, the VTA. When we turn on the stimulator, we create an electric field around the active contact. Any axon inside that field that reaches threshold will fire on each DBS pulse. The size and shape of the VTA depends mainly on amplitude. Higher amplitude pushes the field further, recruiting more fibers. Pulse width. Longer pulses lower the threshold for smaller fibers and expand the VTA. Contact configuration, which contacts are active and whether they are directional. So in practice, you are programming fiber tracts, not just gray matter. Pallidothalamic fibers, hyperdirect projections, internal capsule, limbic fibers, all of these can fall into or out of your VTA as you change parameters. Now the first major mechanism, the fast one. In the off state, STN and GPI show strong beta activity, often in long bursts. The longer those bursts, the worse the bradykinesias and rigidity. When we stimulate the STN at high frequency, around 130 Hz, we drive axons to fire in a high frequency time-locked pattern and disrupt the ongoing slower beta synchrony. Recordings show that high frequency DBS suppresses local beta power and reduces beta coherence between STN, GPI, and motor cortex. If we stimulate instead at beta frequency, around 20 Hz, we can increase beta and actually worsen bradykinesia. This fast disruption of pathological beta explains the rapid improvement in tremor and part of the improvement in rigidity and slowness. Let's now look at the hyperdirect pathway. The STN does not just send output to GPI. It also receives direct excitatory input from motor cortex via cortico-subthalamic fibers. When we stimulate within STN, we send spikes both downstream to GPI and backwards along these fibers to cortex. This is antidromic activation. In recordings, you can see cortical responses that arrive about 1 millisecond after each DBS pulse. So STNDBS is in real-time conversation with the motor cortex. These antidromic spikes can disrupt pathological beta loops at the cortical level and help restore more flexible gamma-rich activity. So mechanism 1 is local beta jamming. Mechanism 2 starts here as a two-way interaction between the subthalamic nucleus and the cortex. Now zoom out to the whole network. Functional imaging shows that STN or GPI stimulation changes activity in thalamus, motor and premotor cortex, brainstem and cerebellar circuits. This tells us DBS is a network intervention. The STN is a gateway, not an isolated node. Here, the idea of connectomics is helpful. Instead of thinking only in XYZ coordinates, we think in terms of connectivity. Which cortical and subcortical areas does this contact talk to? Within the STN, this becomes very practical. A contact in the dorsolateral sensorimotor STN is strongly connected to M1 and SMA and tends to give the best motor benefit. A contact in the more ventromedial, limbic, or associative STN is plugged into mood and cognitive networks and is far more likely to produce affective or behavioral side effects. So two contacts just a few millimeters apart can sit in completely different circuits and produce completely different clinical profiles. DBS works not just because of where the electrode is, but which network it is plugged into. On top of this network routing, chronic stimulation also modulates neurochemistry within these circuits, including dopamine and other transmitters in basal ganglia pathways, which further shapes how these networks behave over time. The third mechanism operates on a much slower time scale. Chronic high-frequency stimulation does more than jam rhythms. Over time, it can induce synaptic plasticity, long-term potentiation, or depression in basal ganglia and cortical circuits, reshape network activity patterns on PET and functional MRI, often normalizing abnormal basal ganglia cortical covariance, modulate neurochemistry, including dopamine release in some experimental and human studies. Clinically, we see this most clearly in dystonia. Improvement builds slowly over weeks or months, and when stimulation stops, symptoms may drift back gradually. That behavior fits with a plastic retraining of the network rather than purely acute effects. How do we turn all of this into practical programming? Think of each parameter as targeting one or more mechanisms. Target and contact. Choose dorsolateral, motor STN to capture hyperdirect and sensorimotor fibers, and avoid limbic networks that drive mood effects. Frequency around 130 Hz, high enough to disrupt beta rather than reinforce it. Avoid beta range frequencies that can worsen slowness. Amplitude, enlarge the VTA to recruit more beneficial fibers, but stop when you hit internal capsule or limbic side effects. That is your therapeutic window. Pulse width. Shorter widths favor large myelinated fibers and give more selectivity. Longer widths expand the VTA but can narrow the therapeutic window. Polarity and directionality. Steer the field away from capsule and limbic areas and towards motor hyperdirect fibers. So when you sit at the programmer, you are not just turning knobs. You are deliberately choosing which fibers, which nucleus subterritory, and which network you want to modulate. To wrap up, here is the framework to remember. Fast layer, milliseconds to seconds. DBS drives axons at high frequency, disrupts pathological beta, and allows prokinetic activity to return. This explains the rapid effects on tremor and some rigidity. Network layer, seconds to hours. Via orthodromic and antidromic pathways, especially the hyperdirect route, DBS reshapes activity across cortico-basal ganglia and cerebellar networks. Connectomics explains benefit and side effects. Plasticity layer, days to months. Chronic stimulation induces synaptic and network reorganization and neurochemical changes, supporting slow, durable improvements, particularly in dystonia. So deep brain stimulation is not just a reversible lesion. It is a multi-layer neuromodulation tool acting across time scales. And even with all this data, we still do not fully understand every mechanism. That means there is real work left for new generation of neurosurgeons and neuroscientists.